Good morning, everyone, and welcome to this European Society of Endocrinology talks. This is a webinar on rare diseases, genetic endocrine tumors with a focus on pancreatic nets. It's a joint webinar from the European Society of Endocrinology, the ENDO-ERN, and the European Society of Pediatric Endocrinology. We warmly welcome you to this webinar and thank the sponsors, in particular Ipsen and Cerba Pharmaceuticals, for supporting this project. This webinar will take you through an hour of discussion on the neuroendocrine tumors, especially related to the pancreatic setting. And we're encouraging all of you attending this webinar to ask a question through the Q&A button at the bottom of the screen. As you can see from the agenda currently displayed, there has been a slight change in the speakers setting due to an unprecedented and unforeseen problem with Professor Ferrone. So I'm chairing this session with my colleague, Professor Beata Koskugla.
Nice to meet you. Yeah, well, I hope that it will be interesting webinar. As you can see, according the agenda, we will start with the presentation, nuclear imaging in neuroendocrine tumors, focusing on pancreatic neuroendocrine tumors. This presentation will be given by Professor Valentina Ambrosini from Italy. Valentina is associate professor from University of Bologna, Department of Medical and Surgical Science, diagnostic imaging and radiotherapy. Professor Ambrosini is a full-time employed physician in nuclear medicine. She is a certificate specialist in nuclear medicine and respiratory medicine. Valentina is a member of ESMO faculty staff. In its advisory board, we were working together. And also, she's in Oncology and Theranostic Committee of European Association on Nuclear Medicine. That you can see that you can face now expert in the field of neuroendocrine tumors and nuclear medicine. Valentina, the floor is yours.
Thank you, Beata, for this nice introduction. I'm going to share my slides now and hope that you can see it. So I'm going to start my presentation by bringing some insight on the nuclear imaging possibility when imaging NET, and especially PNET, although as you may know from articles and papers published, in most cases, the PET-CT is being used in NET in general. There are not many papers focusing on the specific diagnostic capability in the PNET setting. What is important to remember that neuroendocrine tumors can have very different primary tumor sites, and they may present with very heterogeneous behavior that can become apparent also over the course of the natural history of the disease. From the purely diagnostic point of view, PET-CT has to be considered the diagnostic procedure of choice, especially over scintigraphy and SPECT-CT. In fact, the PET-CT allows us to have a very higher accurate characterization of lesion detection, and it allows the unboxing, let's say, of tumor biology, meaning that we can choose among an array of different radiopharmaceuticals that each can depict a particular biological aspect of the tumor cells. In the choice of among the different radiopharmaceuticals available, Of course, several aspects need to be taken into consideration. First of all, the physiological biodistribution of the radiopharmaceutical across the human body in the healthy humans in order to have a very high tumor to background, meaning a very high uptake of the lesion over a cold background. I always like to place this inflamed ice cube to convey this idea, especially to people who are not um, often looking directly at the imaging because we need in order to depict clearly a lesion, we need to have a high uptake in the lesion surrounding a cold background. Then we have to consider availability. Some radiopharmaceutical for PET imaging are not present in every center, or the synthesis is not easy, and we'll go over to that. And also the clinical question. The last 2 decades witnessed an exponential increase in the potential therapeutic application of nuclear medicine in the setting of NET. So nowadays, one of the most frequent questions is, can we treat these patients with PRT? So when this is the clinical question, of course, the choice of the radiopharmaceutical is targeted to the somatostatin receptor ligands. In most cases, in fact, we use radiopharmaceuticals that bind to the somatostatin receptors overexpressed on the NET cells that represent the molecular target for imaging. The diagnostic radiopharmaceuticals that we currently use are all agonists of the receptors and are mostly labeled with 68 gallium, although we'll see some, one in particular is also labeled with 64 copper. Somatostatin receptor imaging with PET-CT can allow us to depict the presence of the tumor and especially of the whole tumor burden, meaning the primary tumor as well as its metastatic spread to nodes and metastatic sites. And of course, the possibility to depict the presence, to demonstrate the presence of somatostatin receptor non-invasively by PET-CT is of crucial importance in the selection of candidates that could benefit from the treatment with PRT. PRT consists in the systemic administration of radiopharmaceuticals that emit a cytotoxic radiation. The radiopharmaceutical that is currently approved for treatment is 177 lutetium dotatate, and is administered with 4 cycles of injection over an extended period of time. And PET-CT can be performed also after treatment in order to assess the response to the targeted treatment. According to guidelines, here I can display the joint guidelines of the Society of Nuclear Medicine, of the American Society of Nuclear Medicine, and the European Society of Nuclear Medicine, and the ESMO guidelines. All agree in the need to perform SST PET-CT for initial staging and for preoperative imaging, as well as for the selection of candidates to PRT, and also for the restaging setting. In this case, we will talk a bit about how to assess response with PET-CT, and also to the possibility to use PET-CT to have a new baseline after the completion of treatment in order to plan further patient's management. The advantages of using SST PET-CT for imaging can be summarized in the fact that this procedure has a very high accuracy for even detecting very small lesions. In the picture here, the red arrow shows a very tiny but focal and pathologic uptake in the pancreatic tail that was not detected by the CT. And in the patient next to it, there is also a very small liver metastasis. The PET-CT has a very high inter-observer agreement, and considering the strong link between the demonstration of somatostatin receptor and the clinical management, it strongly impacts the clinical management itself. In fact, the uptake of somatostatin receptors, radiopharmaceuticals, correlates with the somatostatin expression on tumor cells. And that's why we use this procedure to select the most suitable patients for PRT treatment. The diagnostic radiopharmaceuticals that we currently use are all clinically comparable, although it is well known that they do present a different affinity profile for the somatostatin receptor subtypes. But clinically, we can use them by comparing the visual assessment of, for example, two PET-CT scans acquired with different radiopharmaceuticals across two different examination time. However, of course, since the binding profile to the somatostatin receptor is slightly different, we cannot directly compare the semi-quantitative parameters, in particularly the SUV max, directly when patients have been scanned with one or the other somatostatin receptor analog. FDA approved 68 gallium dotatate, DOTATOC, and 64 copper dotatate. EMA approved gallium DOTATOC in 2016, and there is a European pharmacopoeia for gallium DOTANOC monography that was released this year. If we look at the appropriate use criteria for SST PET-CT imaging, we see that most indications rely in the possibility to depict the presence of neuroendocrine tumor lesions in the setting of the staging before planned surgery. But also, it's interesting to notice that there are two conditions, in particular the evaluation of a mass suggesting of NET but not amenable of biopsy. This is a very interesting setting to discuss about, because the possibility to non-invasively demonstrate the presence of somatostatin receptor is certainly something that drives us towards the confirmation of a neuroendocrine tumor suspicion. However, it has to be said that with no radiopharmaceutical used in PET, we can derive the nature of a lesion. And this is very important to know, because some non-neuroendocrine tumors can express somatostatin receptor and therefore can be avid of the radiopharmaceuticals. So when using the PET-CT in the context of a patient who was not biopsied yet, the final interpretation of the PET-CT result should derive from the evaluation of different factors, including the pretest probability of disease, the laboratory testing, and also the CT appearance. And in this setting, also, it's been considered appropriate to perform SST PET-CT in the patients with biochemical evidence of symptoms suggestive of NET without evidence of CT. This is setting, however, I feel the need to point out that in this particular setting, the correct performance of the biological testing and the clinical assessment, so meaning the core pretest probability of disease, needs to be run very thoughtfully, because we all know that in some setting, we can have, for example, increase in the chromogranin A that does not reflect the presence of a neuroendocrine tumor. What are the pitfalls? When we image patients with the somatostatin SST radiopharmaceutical, we have to consider one fact that is related to size. Very small size lesions cannot be depicted on the PET-CT. But this can be particularly relevant at liver level due to the biodistribution that is often heterogeneous of the radiopharmaceutical at liver level, which is one of the most, not the most frequent site of metastatic spread. False positive can be encountered often at sites of inflammation or infection. So a very important issue is to have a very thoughtful history before PET-CT scanning in order to acquire information about recent trauma, infection, surgery that all can hamper the SST PET-CT imaging reporting. Moreover, some non-neuroendocrine tumors may express somatostatin receptors, including lymphoma, lung cancer, breast cancer, prostate cancer. And in this case, of course, the interpretation of the scan needs to take into consideration also the clinical background. In these pictures, I took these pictures to show you that intense and focal uptake can happen in vertebral hemangioma that should be interpreted with, of course, care in this patient and not be wrongly identified as a site of metastatic spread. In this other case, on the right side of the screen, you can see a focal uptake of a radiopharmaceutical right in the post-surgical abscess in a patient treated for pancreatic NET. Of course, when we look at patients with NET, we have to be aware of the potential risk of dedifferentiation over the course of the disease. And of course, dedifferentiated clones may not be detected by SST PET-CT. Another potential pitfall related to the pancreatic NET is the fact that the biodistribution of somatostatin receptor analogs includes the uncinate process and head of the pancreas. The uptake at this level can be show a different pattern. We can have a very diffuse uptake or a focal uptake. In both cases, even when the intensity of the uptake is higher than the reference liver background, if there are no morphological abnormality on this corresponding CT, this findings should be reported as a pitfall due to physiological biodistribution. On the right-hand side of the screen, on the contrary, you can see a focal uptake corresponding to a morphologically evident lesion that corresponds to the presence of a NET lesion. The concomitant the concomitant administration of somatostatin called analogs for treatment and controlling the symptoms related to NET may reduce the uptake at liver level. This has been portrayed by many publications, and this is why we generally suggest to perform PET-CT after before the following administration of cold somatostatin analogs. And you can see also from this table that the liver SUV max is strongly reduced by the administration of cold somatostatin analogs very close to the PET-CT scanning. A question that is often asked is whether FDG should be performed or not. This is one of the arguments against using FDG in the setting of NET is that it may be negative in patients with well-differentiated lesions. If you look at the data published by the Chung group on the multicenter validation of the NET PET score, including 319 patients with metastatic unresectable JEP-NEN studied with both SST PET-CT and FDG PET-CT, you can see that across all grades, a proportion of patients shows FDG positivity in up to 73% overall. And it's certainly true that as in all the other solid tumors, FDG is prognostic. So a patient with NET showing FDG positivity is associated with a worse outcome than patients with FDG negativity. This is a very prospective, this is a very long study in which 166 GEP-NET patients of all grades were followed up for a median time of 9.8 years, and FDG positivity was associated with a worse prognosis than patients with a negative scan. From a practical point of view and also clinically oriented point of view, I think that this scale proposed by Karfis can depict the three clinical scenarios that we have to distinguish while dealing with patients with NET. On one side, we have the C1, which is the first grade, in which all the lesions are SST PET positive. So they show high uptake for the somatostatin analogs, and FDG is completely negative. A grade 2 in which we have at least one FDG positive lesion, but all of the FDG positive lesions are matched with the somatostatin receptor PET-CT findings. So we have all matched lesions. The one that show FDG uptake also show somatostatin receptor PET positivity. And on the latter grade, we have patients that show a spatial mismatch, meaning that that lesions that are FDG positive are not also showing uptake for the SST radiopharmaceuticals. And these three grades actually corresponds to very different median PFS and OS, and the functional classification proposed by double PET imaging better stratifies the patients with different outcomes, also compared to the WHO grade classification. This may also be due to the fact that often usually patients are stratified according to grade at the first pathological sampling, which can happen many years before the day in which they perform the FDG PET-CT, usually performed when there is a suspicion of progression in a patient that was before showing an indolent disease. The issue of when to perform this FDG PET-CT scanning has been debated in many settings, and there is no standardized guideline, although expert consensus indicate that it should be indicated in patients that are selected based on grade, particularly for NET-G3, NECT, patients showing abnormalities on the diagnostic CT, but that are not matched with SST PET-CT uptake, and in patients before PRT, in patients with G2 or G3, to exclude the presence of mismatched lesions or as a prognostic factor. In a very recent published paper that was promoted by the INES Theranostic Task Force and portrayed among the members of the INES Advisory Board, full agreement, arbitrarily classified as higher than 75% consensus, was reached for three statements in which FDG, supporting the role of FDG in NET, irrespective of grade, when mismatched lesions were present. And the mismatch in this setting was referred to the presence of the lesion that was detectable on the diagnostic CT, but not displaying any somatostatin receptor positivity on PET. And this especially if PRT is contemplated among the treatment options. FDG is also recommended, was considered or enacted before curative intended surgery. A final statement almost reached the threshold for full consensus and stated that FDG should be performed in all NET-G3 as a baseline for response assessment, even in the presence of matched lesions between diagnostic CT and SST PET-CT. One very debated setting issue is also to establish how to assess response with PET-CT. In fact, the guidelines support the use of morphological criteria, mostly RACIS 1.1, that, however, are challenged by some features that are typical of NET. First of all, the slow growth and the possibility to find heterogeneous lesions that can happen spontaneously or in response to therapy. Moreover, the motivation to treat may be different. In patients with indolent or symptomatic disease, the intervention is more oriented to improve the quality of life rather than to extend survival that is, however, quite long. Whereas in the setting of aggressive disease, the objective response assessment becomes crucial for further management. The braces 1.1 are recommended by all guidelines and, however, are not routinely used in the clinic and mostly employed in the setting of clinical trials. Some features of the braces classification, in fact, are not ideal to assess the response on the whole tumor burden. First of all, the fact that the measure is limited to a limited number of lesions, so not depicting the characteristic of the whole tumor burden. The potential misclassification of progressive disease as stable disease due to the slow growth rate typical of NET, and also the fact that therapy may induce density changes other than side, and that bone lesions are not included in the RACES assessment. In fact, it's also interesting to notice that when routine clinical interpretation is compared to RACES, there is a disagreement in about 35% of cases. And this is mostly due to a clinical interpretation overdiagnosing progressive disease in about 32% of cases when co-reading diagnosed stable disease. This comes out as a consequence of errors in target lesion measurements or for overcalling non-target lesion as progression or overcalling new lesions as progressions. In a limited proportion of cases, the clinical interpretation underdiagnosed PD as compared to racist. The morphological criteria all actually show a good correlation among each other and clearly can depict the patient in progressions versus patient in stable disease or partial response. However, size alone cannot describe the lesion features fully, in particular when there is a necrosis component with or without scarring, in cases that present a very high stromal component or edema after therapy, or for the characterization of nodes not reaching the criteria for positivity in size that may be negative on the diagnostic CT but may turn to be positive on the PET CT. There is the issue of clonal heterogeneity, especially in higher grades, and although rare, of cases presenting a pseudoprogression. Finally, one of the biggest advances in the treatment landscape for NET was represented by the introduction of the PRT in routine clinical practice. And however, we have to be aware that most patients treated with PRT actually end up in showing stable disease. These are the results comparing anatomical imaging and SST PET-CT imaging in patients treated with PRT and included in a Spanish national registry. You can see from the yellow arrow that most patients end up in displaying stable disease. So it's more difficult for morphological criteria alone to describe slight changes in lesion size. Moreover, in the post-hoc analysis of the NETTER-1 trial, the first randomized phase 3 trial on the use of PRT in the midgut NET, tumor shrinkage was correlated with PFS only in the octreotide arm, while in patients treated with PRT, PFS did not show, was not significantly affected by tumor shrinkage, indicating that PRT was effective in the treatment of NET without modifying the tumor size. And this also reflects in the objective response rate according to RACES observed in the NETTER-2 trial as compared to the NETTER-1, in which patients with different grades were included, G2, G3 in the NETTER-2 versus predominantly G1 in the NETTER-1. In fact, although appropriate use criteria indicate the possibility to use PET for the assessment of response, there is no agreement on the imaging technique of choice for monitoring PRT response. In the Focus 3 meeting that was promoted by the ENM and included the many panelists also coming from the ENETs, panelists did not agree which was the imaging of choice to assess a response to PRT, and most voted for both the association of both ST PET-CT and contact enhanced triple phase CT. In fact, issues when dealing with SST PET-CT for response assessment have to be dealt with, in particular technical issues, including the injected activity, the uptake time, the presence of extravasation, the reconstruction method, and also the tomograph type, because we have several different generation PET-CT tomographs, and the results, especially the semi-quantitative results that can be obtained, cannot be directly compared. Local practices varies widely, so SST can be performed generally from 3 to 12 months after the end of PRT, and FDG results also are variably present in the management of patients depending on the center in which it is performed. Some centers do perform FDG routinely and other not. And also we have to remember that the reduction in uptake of the somatostatin analogs radiopharmaceutical may not always reveal the presence of a response, but also may conceal the dedifferentiation. The segmentation method for the assessment of PET-CT imaging is not standardized. There have been many attempts to try to define PET-derived parameters to correlate with treatment response, mostly um, indicated some parameters derived from the SUV, tumor to spleen, SUV mean, but none derived any parameter that is standardly employed in every center. More recently, just a few months ago on the JNM 2024, the results of the phase 2 Lumen study were published, and the attention was in this case over the tumor volume expressing somatostatin receptor. In fact, there are some softwares that allow us to quantify the volume of the lesions that express the somatostatin receptor on the whole tumor volume. And in this way, we can directly divide the patients in different prognostic group, as well as the integration of the discordant tumor volume showing FDG positivity and not SST PET-CT. Of course, when we deal with the segmentation methods, of course, are not standardized, and we need to work more in this direction in order to derive which thresholds should be used for the response assessment. When different parameters, morphological and functional, are used in the same setting of patients, the patient are stratified differently. So there is need to work more in this direction. In the setting of other radiopharmaceutical, there are some emerging radiopharmaceuticals that can be of help, in particular the agonist labeled with fluorine. You can see that the background activity in the fluorine indicated by the blue arrows is much lower and help us to depict the presence of more lesions than the usual labeled with the radiopharmaceuticals labeled with gallium. Another step forward is the use of the antagonist. We have several different antagonists that we can use, but they are not registered in most countries, and they show a much higher uptake than the agonist that in this case was gallium dotatate. In particular, I would like to show you this example in which in the A and B, there are the images of a patient obtained with gallium dotatate as compared to the antagonist in the other slides. You see that the uptake in the spleen and in an accessory spleen are evident on the gallium dotatate, but are not evident on the antagonist. So the use of antagonists can help us to depict the real lesions from pitfalls. And of course, the antagonists have already been used in the treatment setting. So as a conclusion, when imaging patients with NET, PET-CT is the gold standard. The most used radiopharmaceutical are the radiopharmaceutical that bind to somatostatin receptors overexpressed on NET, and the most important indication is staging and restaging, and of course, assessment of PRT eligibility. There is an emerging role on the combination of SST PET-CT with diagnostic TC for response assessment, although standardized criteria are lacking. The role of FDG is important to detect disease heterogeneity, but its employment in routine clinical practice generally follows the discussion within an MDT. Emerging radiopharmaceutical are coming out, so we hope to have the possibility to use them in the clinical practice as soon as possible. So thank you for your attention.
Thank you, Valentina, for the great lecture. Thank you so much for a very innovative and very practical lecture. Thank you very much. And we will have, because we're a little bit running of time, we will have time for the quick question from the audience. The first one, thank you for the great presentation. In what manner FDG PET done before PRT affects the future treatment?
Well, basically, the FDG performed before PRT can show us if there are some lesions that show FDG uptake, and this can be differentiated into lesions that are matched or mismatched. If the lesions are matched with the result of the SST PET-CT, we expect a lower response of PRT, lower rate of response, intensity of response, while if these lesions are mismatched, we know for a fact that there are clones that will not be covered by the treatment alone. So this is why I think that classification of CARFIS allows us to differentiate the three settings in which we can stratify our patients.
Okay, thank you very much. And one quick question, because it's very important from the clinical point of view. How do you improve, how we can improve detection of liver metastasis using PET-CT? I'm thinking mainly about gallium PET-CT.
Yeah, well, actually, the detection of liver metastasis with PET-CT can, in some cases, be difficult, especially after treatment, because there is a dishomogeneous uptake of the radiopharmaceutical at liver level. So we can either think of changing or upgrading our radiopharmaceuticals, for example, the fluorinated ifnocta octreotide, which is reimbursed in Belgium since July. Shows that there is allows us to more clearly see the lesions at liver level, and also the possibility to exploit the new PET technology, including the long axial field of view PET, probably allows us to increase the capability of detection of liver lesions. It will be beneficial also to have the possibility to use the antagonist that shows so low background in the physiological sites of uptake, and so they can improve the lesions detection at liver level as well.
Okay, thank you so much. I think that we have to move further.